Your insurance company just denied your prior authorization, and every instinct you have is telling you to appeal. Don't. Not yet. Because there's a specific letter, one single document your doctor can write, that overturns more denials than the formal appeal process ever will. Most doctors never offer to write it. Most patients never know to ask. And insurance companies are counting on both of those things, staying exactly the way they are. This video is for educational purposes only and does not constitute legal or medical advice. Here's what it is, why it works, and exactly how to ask your doctor for it today. When your prior authorization gets denied, the insurance company sends you down a very specific path. File a standard appeal. Wait 30 days. Get denied again. Maybe hire a lawyer. Maybe give up. That path was designed by them, and it works in their favor almost every time. Here's what that costs, real people. The average out-of-pocket expense for a single denied prior authorization, when patients try to pay for the treatment themselves while fighting the denial, runs to about $11,000. That's not a worst-case number. That's approximate average data from patient advocacy research. And here's the part that makes it worse. Under the Affordable Care Act and state-level external review laws, you have appeal rights. Real ons. But the standard internal appeal, the one the denial letter tells you to file, has an overturn rate of only about 11%. 11%. The system hands you a process with a 1 in 9 shot and calls it your remedy. The letter most people never ask for doesn't go through that process at all. It goes around it, and that's exactly why it works. Here's the mechanism. Prior authorization denials almost always come down to one of 3 reasons. The insurer says the treatment isn't medically necessary. They say there's a cheaper alternative you should try first, or they say the documentation your doctor submitted was incomplete. The standard appeal lets you argue with those reasons on paper. The letter changes the game entirely. It's called a letter of medical necessity, and when it's written correctly, with specific clinical language tied directly to your insurer's own coverage criteria, it doesn't just push back on the denial. It dismantles the justification the denial was built on. Here's why most doctors don't offer to write it. A letter of medical necessity takes time, real time. A doctor has to pull your insurer's specific coverage policy for this exact treatment, cross-reference their clinical criteria, and write a letter that addresses those criteria point by point. That's not a 5-minute task. In a system where a primary care physician sees an average of 22 patients a day, that letter is an hour of unpaid administrative work. So they don't bring it up. They wait for you to ask. Now, what makes this letter actually work versus the generic version that doesn't? Most doctors, when a patient pushes hard enough to get a letter, write something like this. My patient requires this treatment. I believe it is medically necessary. That letter gets denied again in about 72 hours because it doesn't engage with the insurer's own language. Every major insurer, United Healthcare, Cigna, Aetna, Blue Cross Blue Shield, publishes clinical coverage policies. They're public documents. They list the exact criteria a treatment must meet to be approved. The letter that overturns denials takes those criteria, word for word, and shows how you meet them. If the policy says the treatment is covered when conservative treatments have failed to provide adequate relief after a minimum of 6 weeks, the letter documents that you tried the conservative treatment, names it, gives the dates, and states the outcome. It speaks the insurer's language. And here's the thing about that. The insurer's own reviewer can no longer check a box that says criteria not met, because the letter just checked it for them. Has your doctor ever actually written a letter of medical necessity for a denial you faced? Drop what happened in the comments. I read every single one. The specific elements your doctor must include, and the one sentence that changes everything. A letter of medical necessity that actually moves the needle has 6 components. 1. Your specific diagnosis with the ICD-10 code. That's the standardized billing and diagnosis code system. 2. The treatment requested with the CPT procedure code. 3. A documented history of what you've already tried, with dates and outcomes. 4. Direct citation of the insurer's own coverage criteria. 5. Clinical evidence, meaning peer-reviewed studies, or published clinical guidelines that supports this treatment for this diagnosis. And 6. The consequence of denial stated plainly in medical terms, what happens to you physically if this treatment doesn't happen. That sixth element is the one most letters leave out, and it's the most powerful sentence in the document. When a letter says, "Denial of this treatment will result in continued deterioration of the patient's condition, likely requiring hospitalization," it changes the risk calculation for the insurance company. Approving a treatment they initially denied is a minor administrative embarrassment. Being responsible for a hospitalization that a letter predicted and they ignored is a liability. Those two things are not the same to their legal department. Here's a specific example. A patient in Ohio was denied prior authorization for a biologic medication for Crohn's disease. The denial cited step therapy requirements, meaning the insurer required the patient to try two cheaper medications first. The patient had already tried both, but the original prior authorization paperwork didn't document the outcomes clearly. The doctor's letter of medical necessity cited the insurer's own step therapy protocol, named both medications with the trial dates and the specific adverse reactions, cited 3 published gastroenterology guidelines supporting the biologic as the appropriate next step, and stated that continued denial risked acute flare requiring emergency hospitalization. The authorization was approved in 4 days. The appeal process would have taken up to 60 days under federal standards. If you've been handed a denial and told your only move is to appeal, now you know that's not true. That's what we break down here every week. The rules they don't explain to you, the options they don't mention. If that's useful to you, subscribe. There's no fluff here, just what actually works. Now, the peer-to-peer review and why the letter sets it up to be decisive. Most people have never heard of peer-to-peer review. Insurance companies don't advertise it. Here's what it is. When a prior authorization is denied, your doctor has the right, under most commercial insurance contracts and under Medicare Advantage plan rules, to request a direct phone call with the insurance company's medical reviewer. Doctor to doctor. No middlemen, no forms. And here's the connection most people miss. A peer-to-peer call without the letter of medical necessity is just a conversation. With it, it's a briefing. Your doctor walks into that call, already holding a document that has preempted every objection. The insurer's reviewer has to engage with clinical evidence on the record, not just check boxes. That changes the dynamic of the call entirely. Studies from the American Medical Association have found that peer-to-peer reviews, when properly documented and requested, overturn denials at a significantly higher rate than standard internal appeals. Some specialty areas, particularly oncology and neurology, see overturn rates above 50% in peer-to-peer review. The standard internal appeal, remember, runs at about 11%. So here's what the full play looks like. Your denial arrives. You call your doctor's office and you ask, specifically, for 2 things. A letter of medical necessity written to your insurer's published coverage criteria, and a peer-to-peer review request filed the same day. Those 2 actions together are not a Hail Mary. They are the documented effective path that the denial letter you received deliberately failed to mention. Now, the timing matters. Under the No Surprises Act and its implementing regulations, and under the ACA's appeals rules, insurers must complete standard appeals within 30 days for non-urgent care and 72 hours for urgent care. But peer-to-peer reviews typically happen much faster, often within 48 to 72 hours of the request for non-urgent cases. That's the window you want. You want the letter and the peer-to-peer request in motion before that appeals clock is halfway through. There's one more thing. If the peer-to-peer review also gets denied, you now have something valuable. You have a documented record of 2 specific clinical judgments being overridden by an insurance company's reviewer. That documentation is exactly what you need if you escalate to an external independent review under your state's external review law. Or, in certain cases, if the denial pattern rises to the level of bad faith insurance practices under state law. You've built a file, and a file is leverage. Let me give you the exact language to use when you call your doctor's office today, because this is where most people stall out. They know they should ask, but they don't know what to say. You call and you say, "I received a prior authorization denial. I'm requesting 2 things. First, a letter of medical necessity written to my insurer's specific coverage criteria for this treatment, with CPT and ICD-10 codes, documented treatment history, and clinical citations. Second, I'm requesting that your office submit a peer-to-peer review request to the insurer's medical director today. Can you tell me who handles those requests in your office? That last question matters. In most practices, peer-to-peer requests go through a nurse navigator, a medical assistant, or an office manager, not the doctor directly. Finding that person gets it done faster. Write that down. Screenshot this moment, because that conversation, that specific ask, is the difference between spending $11,000 out of pocket while an appeal crawls toward a likely rejection and getting your authorization overturned in days. And here's what to do if it still gets denied after all of this. There's a federal process called external independent review that insurance companies genuinely do not want you to know about. It pulls the decision out of their hands entirely and puts it in front of a neutral third-party reviewer they can't influence. That breakdown is already on the channel. One more thing before you go. If this video showed you something your insurance company never told you, tell me this in the comments. What treatment got denied, and how long have you been fighting it? That information helps me know exactly which part of this system to cover next. Every comment I get shapes what we expose here.